I'm Doug Johnston. I'm the Chief of Cardiac Surgery here at Northwestern Medicine in the Bluhm Cardiovascular Institute.
I'm Dan Schimmel, and my role is Cath Lab Director and also Fellowship Director.
I'm Kevin Hodges. I'm a staff cardiac surgeon here, and I'm the director of our robotic and minimally invasive cardiac surgery program.
So we're here to talk about robotic coronary surgery. Dan, I'll start with you. Maybe you can talk a little bit about what's a patient you might consider for a robotic coronary operation.
When I think about coronary disease, a lot of times we think about the three major vessels, but we know that one of them is way more important than the other, right? The left anterior descending artery. And when you have specifically disease in that artery, a LIMA, a left internal mammary artery, is superior to stenting, right? If you have a good target and a good surgical candidate. And so when I see that type of isolated disease and someone who maybe they can or can't tolerate antiplatelet therapy, but they're a good surgical host, that would be a great patient for a LIMA to LAD robotically, where they don't have to have a sternotomy and they get that long-term durable benefit. A young patient, older patient, I mean, it's good for everybody.
So Kevin, what makes a robotic coronary operation different from a standard operation?
So everybody knows standard open heart surgery, and they associate that with a median sternotomy. And that's sort of the biggest limitation after cardiac surgery. A robotic coronary bypass operation means that we use robotic instrumentation to harvest that left internal thoracic artery and then make a small incision directly over the left anterior descending artery and do a direct anastomosis to do that bypass. So we're able to do that most important component of a coronary bypass operation through a very small incision between the ribs and with port access for the mammary harvest.
Then where are we going to be in 5 years with how we evaluate coronary patients for the optimal transcatheter and the optimal minimally invasive or combination of the two?
The surgery is getting more finessed. We have more tools in the cath lab to deal with calcium or total occlusions, and we tackle those challenges all the time. But the truth is medical therapy is better too. And so patients are presenting a little bit later. I do think that complexity will continue to just grow. It'll be new technologies, new advances, and conversations about the patient.
What's coming down the pike in terms of robotic technology? Is there anything new on the horizon, and how does that fit in with our paradigm of taking care of patients here at Northwestern?
Well, I think, it's an exciting time for robotics for sure. I think we're going to see a lot of new technologies and things to facilitate less invasive surgery, in particular less invasive, coronary surgery, as our industry partners get sort of reinvested in this area of surgery.
Well, I want to thank Dr. Schimmel, Dr. Hodges for joining us today. This is a very interesting time in the era of overlapping technologies, and thanks again for joining us.